So I'm Anne Mbiya, anesthesiologist. We welcome all of you for joining us in this webinar on ethical dilemmas in perioperative medicine. This webinar is brought to us by the Association of Anesthesiologists of Uganda, sponsored by Troikaa Pharmaceuticals. They will have an introductory talk in the beginning of the session, and at the end, so this session is going to be an interactive session. So if you have any question for our speaker, use the Q&A to enter your question and comments. Make sure you mute yourself so we can hear the session clearly. So without any further delay, it's a great pleasure for me to introduce our sponsor, Troikaa Pharmaceuticals. I'm just going to hand over to you, Grace, to talk on behalf of Troikaa. Grace, can you hear me? Grace?
Grace, first unmute yourself. You have muted yourself. That's why you're not able to speak.
Good evening, everyone. Prashant, I think maybe you can start. I think Grace is.
Yes.
Okay, Prashant, the floor is yours.
Okay. Thank you, everyone. Thank you, doctors. So I don't think I should tell what is Troikaa. Everyone knows what is Troikaa, but just a brief introduction that Troikaa Pharma is an Indian multinational pharma company with focus on therapeutic segment like pain management and anesthesia and nutraceutical products. All right. Troikaa has been cherishing the trust of medical fraternity for more than 30 years with premium quality product and world-class services. So at our Troikaa, we have a philosophy in imagine and innovate. As a result of that, we have developed our expertise in a unique patented technology platform. All our novel technology-based products are distinctly superior to the conventional versions and have made a difference in the lives of patients in more than 80 countries. Troikaa, wide range of pain management, anesthesia, and nutraceutical products are registered in Uganda, including the globally patented NDDs like Dynapar AQ, that is a Dynapar injection, that is only Dynapar diclofenac injection, which can be given IV bolus. Also, we have a 3 world-class manufacturing plant in India, which are well equipped, where the innovation has taken place. So if I'm allowed, can I share my PPT and I just go through briefly about some of the product? I will not take like more than 2 or 3 minutes.
Yes, it's okay. You can share your slides, Prashant.
Yes, thank you so much, doctor. I think I'm not allowed to share because I'm not the host. So if we can just give me the host authority so I can then share my PPT.
Okay.
Yes.
Fifth. F is not around. So Dr. Aggrey. Dr. Aggrey, you can stop sharing so Prashant can share his slide. Dr. Aggrey, can you hear me? Dr. Aggrey, can you hear me? And share your screen so Prashant can share the slide.
Yes, I can hear you.
Yeah, please unshare your slide. Yeah.
Is it still showing?
Yeah, it's still. So Prashant, you can share your screen?
Yes, I think I can do it now. Yes.
Okay, fine.
Can you see my PPT?
Yes, we can see your PPT. Just put in a slideshow.
All right.
Okay, great.
Yes. Yes. So welcome all delegates again on behalf of Troikaa. So as we have already discussed that what is Troikaa and how we are working on our developing technology and superior products, so I will not take much time on this part. So we have in Uganda we have a rocuronium, that is a product called Rocutroy, okay, and it available in a 5 ml vial, right? So this is just a small comparison between like all the muscle relaxant. If you see, we have atracurium, we have cis atracurium, but if you see the rocuronium, the onset time is just 75 seconds. So that is the benefit of this product. And also, if you see, the clinical duration is just 33 minutes. So basically, you don't require a reversal for such kind of product. So Rocutroy, the benefit is I hope you can see, stable hemodynamics, no histamine release, and successful blend of speed and safety. And easy to use liquid, no refrigeration required during the usage of this product. But while transportation, you require a refrigerator because it's a cold chain product. Now, I'm shifting to our again one more great product, Bupitra Heavy. That is a Bupivacaine Heavy with dextrose. Okay, so why should you use Bupitra Heavy first of all? Because there are so many things available in the market. So this is the reason. If you see, manufactured at fully automatic hands-free line with dual sterilization. And also we also have a terminus sterilization of finished product followed by ETO sterilization of the pack. So we also do the sterilization of the blister pack. So if you see, this is the sterilization number 1, the finished project ampule, and this is sterilization number 2. So this is the machine we are using to sterilize our product. Then we also have our OPC, that is a 1-point cut. Bupitra Heavy ampoules are equipped with OPC system, which does not generate microparticles. Generally, you will agree, whenever you are breaking any ampule, some of the particle may go inside. But we have this facility with Bupitra Heavy that there will be no risk of contamination in the ampule while breaking the ampule. Now my last product for today, that is a Tropofol, which is a propofol from Troikaa. Generally, we call it a painless propofol. Okay, so how we are offering a painless propofol? So this is the machine we are using. The machine is called Avestin. Which what it will does? It will reduce the molecular propofol by less than 200 nanometer. So the molecule will be very less, and there will be very less pain at the site of injection. So this is how we are making our propofol as a nano emulsion. If you see, the measure size range from 0.3 nanometer to 10 nanometer. All right, and this is the hands-free vial manufacturing line. So just today I wanted to show you that how Troikaa is making manufacturing our product. I hope the video is visible to you.
Yes, it is.
So I hope you like the video. By sitting in Uganda, you can see that in how in India our manufacturing plant are working. We have totally automated vial line, and this is the proof of the video. So also the very important information about our own propofol, that if you see, we bring our API from Uticals pharmaceutical, which is there in Europe. Okay, then we bring our glass, that is again from the Switzerland, and we bring our rubber stopper from the France, like Germany. So you can see that how we are careful, how much we are curious about our own quality, because we manufacture our own product. We don't have a third-party manufacturer. So that is the benefit of Troikaa, and you can assure about the quality of the product. So this is just my last slide for today. This is just a comparison of that my propofol or my Troicofol is better than MCT and LCT, because we have a studies, we have a clinical trials for that. LCT, MCT emulsion is just a marketing strategy to just increase the price of propofol, and even it is not that much. It is also provide the same pain as the normal propofol. So if you need this data, if you need this clinical, you can contact me, even me or Grace. We can provide you on soft copy on email. So thank you so much from Troikaa. This is, yes, Dr. Aggrey, over to you.
Thank you very much for this great talk. So our next talk is on ethical dilemmas. So in perioperative medicine, shared decision-making is an important emerging paradigm in clinical medicine. It involves the reconciliation of two views, the physician as the medical experts and the patient with their individual values and viewpoint about present and future medical therapy. Despite its increased acceptance, shared decision-making is hardly new, although the definition has some variability. So it's an honor for me tonight to introduce our speaker, Dr. Aggrey Lubikire. He's an anesthesiologist intensivist at Jinja Regional Referral Hospital. Dr. Aggrey, the floor is yours.
Okay, good evening, everyone. Thank you, Anne, for being the moderator tonight. And also, I thank our sponsors for tonight's CME. That's Troikaa, and then the Association of Anesthesiologists of Uganda. Thank you so much. I hope by the end of this presentation, we'll all be edified with whatever we are going to share. These are our two sponsors, the Association of Anesthesiologists of Uganda and Troikaa. Our topic tonight, ethical dilemmas in perioperative medicine. From the Learner's Dictionary, a dilemma is a difficult choice between unattractive alternatives. And ethics has been defined by many people, but basically, there is a choice between right and wrong, what you ought to do, your moral obligations, your choice that benefits society, your choices that will create fairness and virtues. So in return, you'll find that someone has also a moral belief that will be conflicted. And ethics is not a static thing, it is a continuum. And you will notice that what was ethical in 1980 is not ethical in 2000 as we go ahead. So all of us as medical practitioners, we need to be well acquainted, well versed with current practice, with current norms that are ethically acceptable in our profession as a country, but also at the world. So an ethical dilemma is a conflict between alternatives when no matter what a person does, there will be a compromise principle. There are some ethical principles that are required for someone to be able to practice ethics. There's respect for humanity and dignity. There's social justice, there's fairness. We need to be transparent. We need to be honest, both to ourselves and to the people we serve. We need to be non-discriminatory, but also need to be accountable to ourselves and to the people we are serving. There is a comparison between ethics and the law. It's a bit of similarity. One feeds into the other. The law is basically a systematic body of rules that govern society and its actions of this individual. But ethics is more of about kind of moral principles or philosophy that govern basic human conduct. And so in law, we have a set of rules and regulations, while in ethics, we have a set of guidelines. In law, we are governed by the government. In ethics, we have individuals and professional bodies like the Uganda Medical Council. In terms of publication, the law is expressed and published in writing, and so we have acts of parliament, and we have also abstracts on the other side. If you are caught violating the law, you'll be punished to the full extent of the law as stipulated. So for example, if you murder, you might end up getting life imprisonment. But not all breaches of ethics will lead into violation or into punishment. So basically, we are bound by the law, but we're not bound by ethics. And also the other element that comes into enforcement is the moral aspect. The moral aspect entails the behavior or the personal conduct, while ethics looks at the social behavior and its impact, and the law looks at official or the government expectations of how we behave. All of them feed into each other. So you can be or ethically right, but by law you are wrong. Or the other way around, you could be right by the law, but ethically wrong. So the two can be used interchangeably, and one has to understand the difference before you make a violation. There are 5 ethical principles. We have beneficence, we have normal sense, we have veracity, justice, and autonomy. And so every time we have a moral or an ethical dilemma, we need to find out, are we conflicted in any of these? Because if you don't identify the conflict, then it becomes very hard to reconcile the conflict. Beneficence involves promotion of good, while normal sense talks about doing no harm. The two are different and they're not the same side of the coin. In beneficence, we promote good, and failure to promote good, we end up like failing to diagnose or to treat. We may end up not promoting the best treatment for our patients, or we may end up doing patient abandonment. And in normal sense, this is from a Latin word where we should not do harm. It includes appropriate treatment and execution, and failure to do this will lead to unnecessary or aggressive care to our patients, incompetent treatment, and not referring when we should be referring our patients. The other principle is autonomy, which is respect for others. Auto is one's own, and nomos means rule or principle of the law. So here we need to understand that people are capable to benefit from making their own health decisions. When patients come to us, we need to allow them to be involved in making these decisions. And making decisions by the patients makes them much more satisfied. And so we should be seen to be promoting autonomy. There are times when this can be conflicted, where we can, where it is it, the question at hand is it possible that sometimes we can interfere with patients' autonomy? And yes, it's possible, especially this is under the law of paternalism, which has been a very big debate among different scholars of ethics, but it's possible. I could give a case in point. Michael Jackson, when he wanted to do several surgeries on his face, and some doctors were not willing to go ahead and do the surgeries. So that's where the law of paternalism comes in. And it helps in interfering with the autonomy of the patient who is about to do self-harm to themselves. The other principle is called veracity, which is in Latin meaning honest. And there are 2 kinds of violations when we fail to be honest. It can be either dishonest or willful omission of information. So not telling the whole truth is a lie. So sometimes as medical practitioners, we say what we think should be said, but we don't say everything. And so patients are not able to make the decisions because we've not given them the whole truth. And so both parties have the right to choose if information is there, but also the right to tell the truth. So a patient who coming to me for anesthesia should be able to tell me if they have a risk for allergies, and I should be able to know which kind of allergies among the medication might actually affect them. Also under veracity, if you've made a mistake, it's encouraged that you actually admit, make an apology, either written or oral. to the patient or the person you've aggrieved. And many people actually are not in the habit of doing this, but most patients who sue find out later and they end up suing because they thought you were not ethical enough to tell them the whole truth. And so under veracity, if you end up telling the truth, there are always some risks. You may end up risking your career or some penalties, but most people from research actually have not been sued when they tell the truth. Our last principle under ethics is justice, and which is fairness, and involves treating all patients that come to that seek help with no bias, especially people who come through emergency care, people who have disabilities, and the people who come who are struggling to access care, either because they are very elderly, and also people who come under our care as charity. All these people should not be treated and given any less of care just because you're giving charity. So for example, if you're managing pain and you say this patient I think can do without pain management just because I'm treating them for free. That is not fair at all. How do we manage ethical dilemmas? It has been noted by several scholars that before you get conflict, it is good to acknowledge that you have a conflict at hand. So you recognize the situation which you're calling a dilemma. And then you ask yourself, how do I address this dilemma? So you break it into two questions. What is the question at hand that you are conflicted about? And then what is the ethical principle that you are in conflict with? And that means you go back to the normal sense, beneficence, fairness, and find out where you're conflicted. But also it's very important to recognize that the patient has relatives and also the patient has capacity mentally. So you need to seek guidance, talk to the relative, talk to the patient, but also seek for additional information. If you're not aware about any latest literature, seek for information. And the same thing is also you can actually consult with colleagues. But also you can go ahead and call up the medical council to find out if there is any law relevant to you for guidance in terms of conflict. Also, you can actually sit down and have a critical analysis of your dilemma. And that means you get a colleague and try to break it down and see how you mitigate against getting sued, but at the same time give a good care. And then you come up with a decision that you can be able to be sound enough and justified by your clinical argument, so that at the end of the day, if you get sued and they call another colleague in the same level of experience or expertise, they will agree that you took the decision based on the circumstances available. And above everything, all this should be documented. Now, this is a study that was done by Medscape, where they were looking at over 1,000 doctors, and they were asking them questions to see how ethically we can have dilemmas as doctors. And they asked several questions, and these answers actually are very, very interesting. On the left-hand side, a physician or a friend with an alcohol issue, and you are supposed to disclose this to your superiors, and asked how many people would be willing to report to their colleagues, and 86 were willing, 2 are not willing, 2.3%, and some 11.6 things it depends, which we do not know what it depends on. So you can see that even as colleagues are not willing to report each other, yet morally and ethically we're supposed to be reporting so that we can help our colleagues. The other question was, would you ever discuss patients' information in a situation that did not fully protect their privacy, like social, or while doctors are not, the other doctors are not related? Especially in this era of social media, sometimes people throw out discussions about patients. And so 8.4 were willing to discuss freely, 74.4 are not willing, and 14.2 still say it depends. So you can see that we are constantly having ethical dilemmas, even as physicians. We never seem to have an agreement on anything. And the other question was, should physicians' assistance in suicide be allowed? And you can see 45 are willing, 40 are not willing, and 13.3 say it depends. And on the other side, they're talking about confidentiality. if we knew a patient's medical condition and we broke the confidentiality to prevent harm. Say, for example, a spouse that has HIV and does not disclose to the other partner. 53 were willing to break that confidentiality, 20 are not willing, and 26 is quite very big as a research, as a statistic number, still say it depends. So, which shows still ethically, we still have a lot of dilemmas as colleagues. The other question is it acceptable to perform a procedure that isn't medically warranted for reasons of defensive medicine? 16 were willing to do the surgery. 61.3 are not willing, and 22 say it depends. The other question was, are there times when it's acceptable to cover up or avoid revealing a mistake? 1.6 say yes. 94, which is a very good response, says there's no need to cover up. And 3.5 say it depends. So this carries on, and probably if I look at organ transplant, should it be legal for people who buy organs to transplant if they would not be able to receive on the waiting list? 19 say yes, almost 20, 66.5 say no. And so this actually brings in the question that when can we agree in terms of ethics? And I think that's a big debate. I don't think it's easier to get people as practitioners to agree totally. So from their survey, they realized that different medical practitioners had lots of ethical dilemmas, but the majority of ethical dilemmas were in family physicians. The next group was internal medicine, followed by pediatricians, followed by obstetricians, followed by psychiatry or mental health, followed by emergency medicine, then surgery, then oncology, ophthalmology, and interestingly, anesthesia is 2.3%. So yes, the battle of ethical conflict still carries on. Now, there are two protocols that people have noticed that when you're communicating to patients, we can follow, but also we need to involve our patients as what Dr. Anne has talked about, what we call shared decision making. We need to recognize that the condition does not belong to us. The patient comes to us to seek guidance or help. And so we need to involve them in this decision. This is what we call the class protocol versus what we call the spikes protocol. The class protocol puts the situation in context. That means, say for example, someone has a cancer, and then you look at, if it's a breast cancer, what are the implications of breast cancer? Is it the early stage? Is it late stage? If they go through chemotherapy, what are the complications? If they go through surgery, what are the complications? And we should disclose everything to the full extent so that the patients have chance to discuss and they decide, and then come back to us. And that means we should be listening and listening actively. Their wishes, not participating in this by giving our views until they've made up their choices. We should also acknowledge the situation that they are in, the predicament that faces them, but acknowledge them as they are, and we should be patient with them when they come back to us, whatever decision they've decided. Whatever they decide, we should have a strategy. We should try and do more of education, but we shouldn't be seen to be coercing them from the chemotherapy as a choice. And then, as a summary, we need to document the whole discussion, the choices, our views versus their choices, and all whoever was around as a chaperone. In the spikes protocol, setting up the interview situation is very, very important. And this is especially designed to do breaking bad news. Like, say, for example, someone has HIV. You cannot just break the information when they are in the group. You need to make them sit somewhere where it's private enough and see how you approach the idea. The other thing is you need to assess their perception. Do they think actually they have a debilitating illness like HIV? so that by the time you break the news, you've assessed their perception. And sometimes you may ask them who is very, very important to them that you may seek and obtain invitation for others. If you can, and which is required of us, you give the knowledge and information that you know about the subject. And if you think you're not knowledgeable enough, then request that you get the most knowledgeable person about the subject before you start discussing and exposing your ignorance. Then you should be very empathic and sensitive to the patient's emotions. If they are crying, offer them tissue or ask someone else as a counselor to be available. And then also come up with a strategy on how you can help them. For example, if they need to start on HIV therapy, do you want to treat the opportunistic infections first or you want to go full blast? So you need to come up with a strategy and then document everything as part of your discussion. Documentation, I cannot really emphasize this, is very, very important when you have ethical dilemmas. Make sure you document and make sure that this is noted down, because in law, if it wasn't documented, then it wasn't done. Still under shared decision-making, you need to find yourself several questions to be answered. And most of these, if you don't think ahead, then patients will also get stranded. Why you need to discuss with the patient, who exactly needs to be available in the discussion, where can this be done, how will it be done, what will be most appropriate to have this discussion. So there's a mnemonic called SHARE, where you patient, help your patient explore and compare treatment options, safe chemotherapy, radiotherapy, or surgery. Assess your patient's preferences and values. Some people would prefer no treatment despite everything being available. And then reach a decision and then see if you can evaluate your patient's decision. This is decision making, and this has been known to mitigate against concept called the reasonable patient. It was a case that was very famous in the United Kingdom. It has kind of formed our practice at present. This briefly, it's a discussion. He did not talk about, hello, Anna? Hello, Dr. Mbiya? Hello? So during this, the discussion of the obstetrician, this obstetrician didn't disclose the risk for shoulder dystocia, and also did not say the risk was 10%, but also the option that she could easily get a cesarean section. So when she went in labor, she took 10 minutes struggling
Dr.
to
Aggrey?
deliver. Yes, please.
Dr. Aggrey, please, could you share your screen?
Okay. Are we back?
Yes, we are back.
Okay, so the patient was Montgomery. That was 1999 in the United Kingdom, where she was a non-diabetic, prime gravid isolated for delivery, and the obstetrician who was seeing her during the discussion did not disclose what was supposedly very important to the patient, and that has been called material risk. And this material risk was the fact that he did not disclose that Her being diabetic, there was a risk of having a big baby. A big baby would easily result into shoulder dystocia, and the risk was about 10% in her question. And if she got obstructed, that would easily result into hypoxia for the baby and potentially cerebral palsy. But to mitigate that, you should have given an option of a cesarean section. Now, unfortunately, as events unfolded, the mother went into labor and she got obstructed and spent 10 minutes when they were trying to deliver her under forceps. Unfortunately, the baby ended up with cerebral palsy. So later when she went to inquire what had happened, she realized they could have offered her a cesarean section, which was not offered as part of her consent process. And so she sued the hospital. And later the hospital decided to throw it back to the obstetrician because they held him culpable. Him having been a professional should have discussed all the material risks to the patient. And so this lady was awarded £5.6 million in 2016 with damages. However, the practice has now changed. And the practice now is we need to understand who the reasonable patient is. That means that every patient deserves to know whatever is concerning their condition and whatever will concern. And so now, which has now evolved close, everything that we think is the risk, the patient has the right to know risk. And through the trials, jurors or the High Court judges, that it cannot be left to the doctor to determine what is reasonable. The move is to what a patient I would attach as important to them. Involved in discussions, therefore need to be sufficiently well informed and trained and informed consent. And they must be able to, they may need more information and great that they can make a consent, a right decision. Currently, we are required as doctors to disclose all risks to the patient, and these are termed as negligence in terms of risk required to disclose everything. The other area of conflict that arises a lot in our is to take treatment. And normally we have legal frameworks for treating, and every country normally has what we call the statutory law is more informative, or the doctrine of necessity, while the statutory law is made by Parliament. And normally every is at hand, under which time they can treat you. So this now, when we get COVID patients, we do not even need to seek their consent because the government has already authorized the treatment. We all belong to the government. Most of the patients that I think all the patients that are receiving COVID treatment do not sign any consent for this because the government has passed a law that is going to treat them, and if they don't get treatment because of them refusing, then we're also held responsible. I hope all of us are familiar with what we call the Patient's Charter in Uganda. This was made by the Health Consumers Association together with the Ministry of Health. And it has 20 bullets that are rights and privileges to our patients. This 20-page booklet, because if you get to be sued, they refer to this document quite a lot. It's called the Patient's Charter. I encourage you to look at it because it has 20 parts that give autonomy to your patients or to our patients, and we need to be conversant with this. The other area that brings conflict is the capacity of the patient. In 2005, a Mental Health Act was passed in which they used to determine patients that are deemed to have less capacity. And so areas where patients have had dementia, any reason why they have impairment or delirium, if they have a learning disability, if they've had a brain injury, like traumatic brain injury, a stroke, any mental illness, or other difference of drugs and alcohol. It's our duty of occupational health physicians, mental capacity. And here they look at 5 things, is to assume that the patient has capacity, as the patient doesn't have capacity. We need to establish if they have capacity. We need to support our patients to make, and we have this, make sure that this is respected. And making unwise decisions, we should be there to be able to make sure that they are making the right choices as those decisions. And whatever we decide should, but also we should be restrictive in terms of making decisions based on mental capacity. Someone has been found not to have capacity, councils or the medical councils, or has been put in the legal document, can to decide. Say, for example, if I have a parent that gets maybe the person named in the will to act in their interest, lacking capacity, deciding for them. So, okay, like it happens in Europe, then the medical.
Hello, Dr. Aggrey. Dr. Aggrey. Dr. Aggrey, can you hear me?
Yeah, I can hear you.
Okay, fine, we are back. So you can go ahead.
Okay, so sometimes you get a situation where quota do not. Thank
Dr. Aggrey.
You get a patient ER or in theater, that's not legally possible.
Dr. Aggrey.
Yes, please.
We can't hear you clearly. If you can, we can't hear you clearly. No, we can't hear you clearly.
Yes, please.
We can't hear you clearly. Could you please disconnect and connect back and see, because we can't hear you clearly.
Okay. Okay.
Sorry for this technical issue.
Is that any better?
Yeah, I can hear you.
Dr. Anne?
Yes, it's better. I can hear you. Please share your screen. Dr. Aggrey. Sorry for this technical issue. Yeah. Dr. Aggrey. Okay, fine.
Yes.
We can't hear you. Hello, Dr. Aggrey.
So,
we can't hear you. Dr. Aggrey, we can't hear you. Dr. Aggrey.
Okay.
Dr. Aggrey. Dr. Aggrey, can you hear me? Can you hear me?
That okay?
No, it's not okay. Could you please use your mobile phone internet and share with your computer? That should work. Use the mobile phone. Dr. Aggrey?
And can you hear me now?
Yes, I can hear you. Yeah.
Okay.
Yeah, you can go.
My apologies, dear listeners. So there are times when we are faced with a situation of not resuscitate. So, for example, needs to be resuscitated.
Dr. Aggrey, we can't hear you.
Can you hear me now?
Yes, I can hear you now.
Okay, so in situation of DNR, we only do not resuscitate patients if we have a living next of kin. However, if someone has it written on their body, it's not legally binding at all. So we need to be very, very conversant with such situations so that we do not fall prey to the law. Now, there are times when also we have ethical dilemmas in the OR. I'll put a slide in the OR. You have a patient who is either brought by the surgeon, and then there's a team that supports the surgeon. So you have the anesthesiologist, you have the nurses, sometimes you have the resident, you have the fellows, and then the medical students. Now, there is a famous case in America where an attending surgeon was supervising students in two different operating rooms. And in one of the rooms, I think the students made a mistake, and the patient somehow end up getting a cardiac arrest and dying. And so there's a famous case called the wrongness of being in two places at once, and which can happen to any of us, like especially when you're supervising postgraduates. Sometimes you find that they are running 5 rooms and you're only one physician attending, and you're trying to run from one room to another. If any of your fellows or residents or postgraduates make a mistake, you are held responsible because you are the attending physician. And this was the case whereby when the residents made a mistake, the attending physician was held responsible for not being vigilant enough, but also not realizing the limitations of his residents in being able to execute the task that he gave them. Despite this being recognized with most of the training medical schools, that because of shortage of staff, they still end up juggling around. But in the event that there's a mistake, at least be sure that you can defend yourself. But normally you end up falling prey. Very importantly, how can we mitigate against falling prey when we are conflicted or when we have medical dilemmas or ethical dilemmas? Most importantly, we need to communicate, and this means we need to involve the patient from the very word go and relatives. And in this communication, we need to have our fellow physicians that will back us up, but also people on the patient side, besides just the patient, as chaperones. This communication needs to be documented so that at least you have witnesses that in the event that there is a legal suit, you had all the paperwork in place. And then we need to communicate the documentation to those that we think are relevant or in the know. And that means the two parties have to get copies of the communication in the event that some people turn around. And then we need to document this communication, that it was the patients with the relatives, our colleagues, and have retrieved their documentation for posterity. Now, just to close up, we have a famous case where Elia was traveling on a train, and in this train there was a nice looking lady who he smiled at. And she smiled back and came and sat close to him and whispered in his ear, "If you do not give me all the money you have on you, I'll scream and people come and beat you up." And he just looked like he was not hearing anything. And he took out a piece of paper and a pen and wrote that, "I do not hear and understand what you are saying. Please write it on paper." And she wrote what she had just said on paper: "Give me all the money you have on you, lest I scream and people beat you up." After that, he picked the paper, put it in his pocket, and then stood up and spoke, "I hear you right and clear. So you can go ahead since I have the documentation." So I hope all of us realize that it's very, very important to document everything. Thank you so much.
Okay. Thank you, Dr. Aggrey, for this outstanding and informative talk. I have one question from Fiona. He's asking. Yes, Dr. Aggrey, can you hear me? Dr. Aggrey. Hello? Dr. Aggrey. The network. Dr. Aggrey.
Yes, I can hear you. Yes, please, I can hear you.
Okay, we have a question from Fiona. She's asking, who determines what detail is enough?
I can hear you.
I have one question from Fiona. She's asking, who determines what detail is enough? Yes, Aggrey. Hello? The network is bad. Hello, Dr. Aggrey. Hello? Hello, Dr. Aggrey, can you hear me?
Dr. Anne, I think he left the meeting. That's why he cannot hear you.
Yeah. So we can have a talk with our sponsors while Dr. Aggrey is trying to reconnect. So, Prasha?
Yes, Dr.
The
Anne.
floor is your, the floor is yours.
Can you hear me now?
Yeah, he's back.
Okay, he's back. Yes, we can hear you. So, Aggrey, welcome back.
Okay, so to answer Fiona's question,
Yeah.
the practicing physician should be well versed with the subject. Say, for example, if the medical council does not
Dr. Aggrey. Dr. Aggrey.
I should also be fine the pertaining to the subject. Yes, please.
We can't hear you clearly, please. If I don't know
can
if
you
you
hear
can.
me?
Now I can hear you, but while talking, your sound is not clear, so we can't hear your answer. Hello, Dr. Aggrey.
Yes.
So if you can repeat
can
again.
you hear me now?
Yes, I can hear you now.
Okay, so what I was saying,
yes,
that any practicing physician that has a patient at hand should be knowledgeable enough to know the risks of whatever they're going to do. And I gave a scenario that if I'm going to do a spinal for Fiona, it is my mandate as a physician to know all the material risks that are involved in doing the spinal. Say, for instance, if I was going to do Fiona's spinal, I need to disclose to her that when I do your spinal, you have a risk of 1 to 2% of getting a posterior puncture headache. You have a risk of infection, which is meningitis 1 in a quarter of a million. You have a risk of getting nerve injuries, 1 in 1,000. You may get paresthesia, which is temporary. 1 in 100,000, you may get temporary nerve injury, which will resolve in 6 months. 1 in 200,000, you get permanent nerve injury. And also the things that can potentially cause you nerve injury could be idiosyncratic reactions of the drug. It could be how I needle the needle in your spinal nerves that could cause nerve injury. Like most times when people are doing spinals and patients get paresthesia, people are always excited. And yet they should be withdrawing the needle because they are into the nerve. And the other thing is you talk about things like chlorhexidine. If you don't clean up chlorhexidine, you can actually cause chemical arachnoiditis. And then also you need to talk about things like failure. In the event that I do not succeed the first time, I should try another time. And the risk is about 5% for epidurals and 1 to 3% for spinals, for an experienced person of your stature, like Fiona, a practicing anesthesiologist. So it is your duty as a practitioner to know the extent of the risks that you are subjecting the patient. And so in the event that you get sued for having not disclosed all this, you do not expect medical counsel to talk on your behalf. You as a qualified physician should be able to justify why you did not disclose these risks. And that's why the hospital did not defend the obstetrician and left the obstetrician to be thrown under the bus for not having disclosed the risk of 10% of shoulder dystocia to a diabetic mother. I hope that answers your question.
Okay, thank you very much, Dr. Aggrey. You
Yes,
can
please.
also unmute yourself and ask questions to Dr. Aggrey. He's ready to answer any question from you guys. You can mute yourself and ask questions. You can raise your hand, so I unmute you, so you can ask question directly to Dr. Aggrey. So far, no question in the Q&A. So let us have our sponsored Troikaa to give us their closing remarks. Blanchard, the floor is yours.
Thank you, Dr. Anne. I would like to introduce my senior colleague, Mr. Santosh Singh, who will be giving the closing remarks. So, Santosh, sir.
Good evening, doctors and panelists. Thanks a lot for giving us opportunity to talk on such a nice platform. And I must thank Dr. Aggrey for giving such a lucid presentation on dilemma and the laws, how to treat the patient. But when it comes to Troikaa, especially our products are available here, and it has been registered through NDA. Dynapar AQ, which is available in all National Referral Hospital and all referral hospital through NMS, and in all mission hospital, it can be procured through JMS, and in all leading hospitals, it is available. And Dynapar AQ is the only diclofenac can be given IV bolus, IV infusion, intradeltoid, and intragluteal. And also, I just wanted to remind Propofol, please support our brand when you're doing the surgeries. Propofol, painless Propofol, and also you can use when you are like ICU sedation. And then when you are doing this thing, Bupitra Heavy, Bupioken, for regional blocks, you can trust on Bupitra Heavy, which is the only brand with a dual sterilize and with 1 point cut ampule. So I would again thanks to AAU for giving us opportunity to talk on such a platform. And I just must request everyone to support Troikaa so that we can support AAU every time. Thanks a lot and have a nice evening. Stay safe. Thank you.